Welcome to Orthodontic Smiles, the podcast designed for all dentists and their staffs that practice orthodontics. Hi, I'm your host, Dr. Ed Gonzalez. The sponsor of our show today is the American Orthodontic Society. This is episode 7 of Orthodontic Smiles. What a special surprise guest we have today. We're very honored today to have Dr. Luis Carriere. That name Carriere now will go down in history along with some wonderful orthodontists like Tweed and McNamara and Prophet and Andrews. He has made such a name for himself over a very short period of time because of his innovative techniques. And so we're very, very proud to have you with us, Luis. You happen to be in Phoenix. We caught you at the right time at one of your Carriere symposiums hosted by Henry Schein Orthodontics. So thank you for being with us.
Thank you to you, Ed. The pleasure is absolutely all mine. And I'm very pleased to be here with all the American Society of Orthodontics.
Yes. Well, let's get started. I want to delve into a little bit of Luis Carriere, the man. You come from a family of orthodontists, I understand.
Correct.
Your father practiced orthodontics, and did you develop the Carriere Institute, or was that something that your father had and then you made it grow?
Yeah, my father is an orthodontist, and I have been blessed in life to be able to work with him for already more than 25 years. And aside of being my father and being an orthodontist, he's also my inspiration and my mentor, because I have to tell you that I have learned more orthodontics from him. That all the special details, all the small things, all the everything of that has made me
famous. Made you famous?
Not famous, but made me a correct orthodontist are things that have been told by my father to me. No? Yeah, So I'm very happy to be able to have this experience in life, no? That having at the same time of having a father, having a friend, and a professor.
And having a mentor. And that's the wonderful thing about having a mentor, is that they have made the mistakes before you.
Correct.
And they instill the proper way to do things. And I have had one myself, and it made all the difference in the world in my career. You not only are a dentist, but you're an orthodontist, but then you went on after and got your PhD in orthodontics.
Correct.
And what made you do that?
You know, I was looking for knowing a little bit more deeply on all the area of that I was interested about the sagittal correction and about the motion appliance. No?
Was it because of the research?
That's it.
Components.
That's it. So I wanted to be more talented on the research area. So this pushed me to go for the PhD. You know, and I tell you, I learned a lot. I learned a lot on this process of the PhD, in which gave me this point of knowledge and criticism to be able to also brainstorm better all the projects that I was involved with. You know? So that's it. So although I am not a scientist, I consider myself more a clinician. At this point, this PhD gave me this knowledge to know much more about the scientific aspect and have more criticism inside myself. No?
Now, were you working on the motion appliance? Back then, it was called the Carriere distalizer. Were
Correct.
you working on that during your PhD?
Yeah, I was working on that during my PhD. And, the motion appliance that before was called the distalizer, it's an appliance that we decided to move this name into motion because distalizer was just focusing on the distalization. Well, this appliance has a 360 degrees approach onto the areas that is covering a little bit the orthodontic treatment. So this appliance is working not only into the accomplishment of the sagittal correction, occlusally speaking, with the molars, premolars, and canines with a nice rotation, but also inviting the mandible to be relocated forward, balancing the relation in between the maxilla and the mandible, opening in many times the airway of the patient when it is obstructed, and balancing the temporomandibular structures, all of them related to the malocclusion that we are dealing with.
Yeah. Well, many times now, after many years have passed using headgears and things like that, we now know that perhaps that wasn't the best thing for the patient's airway. I was often wondering whether or not the fact that we were using the word Carriere distalizer was more of a marketing change, or was it a scientific change, I guess?
Well, it was a kind of comprehensive change in which we wanted not to misunderstood which was the action of the appliance. That's it. No? And the name was driving us into misunderstanding of that is this distalization, which is not. So this is the reason why we moved into something more comprehensive for the doctors, to understand the action.
Well, one of the other things that I'm curious about is the change now with sagittal first.
Mm-hmm.
It's a little confusing to me. I'm a pediatric dentist, so
Correct.
I have obviously done a lot of early treatment cases,
Mm-hmm.
and I guess the way we have looked at developing the mandible was doing the transverse first,
Mm-hmm.
so that the mandible can move forward
Mm-hmm.
into the proper occlusion.
Correct.
Hearing now that you are promoting sagittal first is a
Mm-hmm.
little bit confusing to me.
The concept is that when we deal with a class 2 or a class 3, even in mixed dentitions or growing patients or adult patients that are non-growing, we try to reclassify the case into a class 1 malocclusion. And from the class 1, solve the peripheral problems. If we are dealing in a patient that has a transversal deficiency as together with the sagittal deficiency and retrusion of the mandible, what we are doing in this mixed dentition is, first of all, we place the sagittal, we place the motion appliance, we accomplish the sagittal correction, we invite to the mandible to establish an adequate relation with the maxilla, and then we switch into the transversal and correct the transversal also in this first phase or phase 1 treatment on mixed dentition. Okay? So we address the transversal, but we also correct the sagittal at the beginning because it's more clean. It's more clean the movement that we pretend to generate. Now, if we have a patient that has only transversal deficiency, of course, we always go for transversal deficiency in this particular case that does not need sagittal correction. Okay?
Right.
Now, if we work in mixed dentition on class 3s, what we do is that we work on transversal and sagittal at the same time, because what we are more inviting is the mandible to be repositioned back in relation with the maxilla. And the maxilla is going to be the anchorage, the area where we anchor for producing this movement with the class 3 motion appliance. So
let me just stop you just one moment for those who may not have been following you as closely as I have watched the different phases of treatment that you provide, and that you're using an RPE on the
Correct.
upper and using the class 3 motion on the lower. So you're basically doing
simultaneously.
Simultaneously. Okay.
Correct.
So we're correcting the transverse and the sagittal components at the same time. This is in the early mixed dentition.
Correct.
Okay.
So then, when we are on the phase 2 treatment, it means patients that already changed the temporary teeth and now are with the permanent teeth, then we address always the treatments sagittal first. We don't care about the transversal deficiency at this moment. We don't care about the vertical component at this moment. We just try to reclassify the case from a class 2 scenario into a simple class 1 scenario. From this standpoint, we correct the transversal if necessary. Or we try to reclassify a class 3 case from the class 3 scenario into a class 1 scenario. And from that standpoint, correct the transversal if necessary in this particular case. So we try to reclassify the case into a class 1 scenario.
Yeah, it's easier to treat a class 1 than it is in any other type of case.
That's it.
So the sagittal correction just brings the patient to walking into your office as a class 1.
Correct.
Very good. Very good. Go ahead.
So the question is that the patient is if Dr. Engel classified orthodontics in 3 types of malocclusion, and he didn't classify orthodontics on the transversal or vertical aspect. He classified orthodontics about the sagittal component in order to let us know which type of patient we were dealing with. No? So this means also, once again, that the sagittal component is the most difficult element to solve in orthodontics nowadays. So we try to remove the problem at the beginning and face the treatment from a simple standpoint.
You developed the Carriere bracket. Was
Correct.
that development related to what position the teeth were in at the end of the sagittal treatment? And let me give you the reason why I'm asking this question. As you use the motion appliance, the class 2 motion appliance, sometimes you end up with the cuspids seem to be more distal than their root.
Okay.
Did you develop the bracket to accommodate to that positioning?
Well, in fact that this is what you say. It seems, but they are not. No, the appliance is an appliance that is rigid, and the molars are also bonded to this appliance. So this is a bar that is positioned on the upper first molar and is positioned on the canine. And we are hooking rubber bands on the canine. The canine is saying, hey, I want to be inclined. I want to be tipped, right?
Right.
Because of the elastics. But the molar is telling to the canine, look, canine, you cannot incline because I also bonded to this appliance. And if you incline, I would disappear inside of the gingiva of the patient, I would be completely disappeared and intruded completely. So the molar is controlling the vertical position of the canine, So there is apparently a sensation that we could have tipping, but we are not having tipping of the canine at this level.
Okay.
Now, another interesting thing about the bracket is that we developed the bracket thinking on physiology. Orthodontic treatment is a matter of cellular cells who resorb bone and cells to generate new bone. It's a matter of osteoclast and osteoblast. And what we need is to generate forces that are gentle enough, smooth enough to do not compress the vessels that irrigates the periodontal membrane, that those vessels brings blood with oxygen and nutrients to the cells that are responsible of remodeling bone and generating new bone. So we try to avoid ischemia. And ischemia can be perfectly avoided if we use a passive self-ligating bracket in which the friction in between the wire and the bracket is ultra smooth or almost zero, right? But at the same time, this has to be completely accompanied by the smart archware sequence that will be changed in the proper moment. In the moment in which the slot of the bracket is aligned enough to welcome the next section of wire without many competing forces that would generate ischemic areas of resorption or anapposition areas of bone. No?
So the concept of your particular bracket then is less friction, therefore less non-anatomic ischemia.
That's it.
Okay.
And trying to take advantage of the physiology. We know that the vessels that irrigate the periodontal membrane, they have an internal pressure of 20 to 26 grams per square centimeter. This 20 to 26 grams per square centimeter can be easily compressed if with an excess of force, and this would be highlighting some discomfort or pain on the periodontal area for the patient. This is a typical sign of ischemia, and is it a typical sign also of loss of efficiency? Because if we create ischemia, we create necrotic tissue or hyalinic tissue, and this hyalinic tissue has to recover and settle again into the normality in order to establish a movement. So this is a loss of efficiency. No?
Great, wonderful. Let me ask you a couple of other questions that were often on my mind since I use your appliance so often. When we first started, what year did Henry Schein start to market your product?
Yeah, well, when we first started, we started with a company of Dallas, of Texas, of Lubbock, Texas.
Class 1, wasn't it?
Class 1 orthodontics with Jim Reynolds, you know.
Yeah.
Jim Reynolds was an orthodontist and the owner of the company. And he was a very interesting man. Not only a great human being, but also a very active man who wanted to bring always new technologies. No? So he he established the possibility of generating the motion, of fabricating the motion through class 1. And also when we came back, we came with the bracket. The bracket, Jim was at that time not focusing completely on the motion, so he presented me to the ortho-organizers people. Then ortho-organizers was very much interested on the bracket, and we gave a license to ortho-organizers.
What year was that?
Probably 2005, 2006, 2005. I think 2005.
Yeah.
And then Henry Schein, who is a company that was not on the ortho field at that time for the specialty, he wanted to generate or create a branch of the company which would be Henry Schein Orthodontics. And they focused on the market to see which were the innovations out there. No? And they realized, or they saw that our approach of the sagittal first and the motion appliance together with the SLX bracket, it could be an interesting subject because it was very innovative and different to everything else. No?
Right.
So what they did is to acquire class 1 and Henry Schein and ortho-organizers and generate and create Henry Schein Orthodontics. So now we have a beautiful company that it's on my completely fits beautifully with my way of thinking. No?
That they have done a great job of marketing your product. There's no doubt about that.
Yeah, but the type of company, no, is very compromised with the help to the community. Henry Schein is a company that, if you look at the history of the company, they are, when there is a disaster in everywhere of the world, the first to arrive with help is Henry Schein. No? Has been selected the most ethical company since many years, since several years of the world. and has all types of awards of the payback that they do on the society,
Yeah.
which I like very much. This is for me something that that is an added value of this company and makes me feel so comfortable working with them.
It was a good match for you.
For me, absolutely, absolutely.
Well, the reason I was asking you what year, because I remember receiving from him, Henry Schein, a few of your appliances to try, and it was soon after they had taken over the product. And I remember the very first one that I put on, which was a Carriere distalizer,
Correct.
was on my grandson. And the reason,
Yeah.
And he was a significant class 2 skeletal. And I wanted to try it first on him because I got to see him every day. And so I was able to look at it and say, all right, well, if this thing doesn't work, then I can take it off tomorrow, rather than wait for a patient a whole month before they come in. The appliance worked miracles. I mean, on him. He has a beautiful class 1 dentition now after completing the orthodontics. But for the longest time, everyone at Henry Schein was telling me, this appliance is not designed for class 2 skeletal.
Because it was a moment, as you know, Ed, it's a moment in which you see things, but you don't really understand what is this appliance about. There is a learning curve. You generate an appliance that is intended to solve the class 2s, then you realize the effects that it's doing, then you observe, and the observations along time drive you to what is really doing this appliance. So I have been learning since all those years a lot about this appliance. It is not a matter of knowing everything about the appliance when you release that, You realize about this when you see many cases, and then you see, hey, look, this happens in here, this happens that, this happens that. So you're learning. And today, I know how it works beautifully, but I tell you, not many years ago, I was not knowing that much as I know today about this appliance.
Yeah, when you first started using it, you didn't realize that it was going to help correct a class 2 skeletal, and it does that miraculously.
And interestingly, interestingly, on the cases that they have temporomandibular disorders on class 2, they work beautifully because this repositioning of the mandible in relation with the maxilla invites to this anteriorly displaced disc to be relocated in the correct position. So we have seen a consistent release of the temporomandibular signs in many patients. Of course, we cannot promise that we are going to solve this problem, but what we can do and explain to the patient is that possibly we can help them into this subject.
Yeah, well, I always tell the story of the use of the Carriere distalizer, and when I was told that it wasn't able to be used for class 2 skeletals, I happened to have had a patient come in who I had scheduled to install a Herbst appliance. Unfortunately, the lab did not get it to me at the appropriate appointment date, and the mother paid for the entire case up front on the day that was supposed to get the Herbst. I told my staff, I said, we're going to put something in on this young man before he leaves, obviously. And I happened to put the Carriere distalizer. I saw the young man a month later, and Luis, he had almost totally corrected his skeletal class 2 within a month. By the second and third month, he was super class 1 in the molars, and the bite had opened perfectly. So I show that case very often to my students when I talk about how to correct a skeletal class 2. What was once the most difficult orthodontic type of case to correct now has become one of the easiest cases to correct.
Correct. You know, Ed, it's a matter of being. It's a matter of being responsible. Not when we place the motion at the beginning, when we started with the motion, we were seeing signs of this, that it was working beautifully on the reposition of the mandible. But we could not state that because the level of knowledge of the appliance was not there. You know, we needed to proceed seeing many patients in order to be able to say, hey, it's working this. No? So this is why it has been an evolution on the message of the motion, because we have been waiting to be able to when we say something, it's because it's happening. No?
Right, that's good. Well, talk to me a little bit, since I'm a pediatric dentist, and we do have a lot of pediatric dentists that listen to our podcast. Talk to me a little bit about the use of the distalizer with primary teeth.
Yes.
Perhaps when the 6-year molars are in, and we wanted to correct a class 2 position of the molar.
Yeah, it's working amazingly. What we do in mixed dentition, when we are facing patients of 7 years old, in which there is a period of time that the patient is not going to change teeth, they have 12 teeth to change, but this will be a silent moment. If the patient is exhibiting a retrusive mandible is then where we place the motion, to invite this mandible to be positioned properly in relation with the maxilla.
You still stay with a sagittal first?
Always, yeah.
Okay.
And then if there is a transversal, after accomplishing that, we go for the transversal correction also with a removable appliance, with a screw or whatever, or a fixed Hyrex to open the upper. But what we do in mixed dentition in class 2 and also in class 3 is overcorrection, because those patients that they have a class 2 malocclusion in mixed dentition or class 3 malocclusion, the temporary teeth, the occlusal area of the temporary teeth is not stable in occlusion with the lowers, because the anatomy is not there. It's not like the permanent teeth that they match perfectly. No, the temporary teeth, they are not designed to match perfectly. They are designed a little bit to grind. So
flat occlusal plane. Yeah,
that's it. So this is generating a lot of instability of the occlusion on those patients that are mixed dentition. So when we correct the sagittal first, if it is a class 2, we overcorrect a little bit. We leave the patient a little bit in class 3 posterior occlusion. And if it is a class 2, we overcorrect. But a class 3, we overcorrect. It means that we bring a class 3 into a class 2 scenario. And sometimes, if the genetic is there and we see a mandible that is going to grow a lot, we leave the case in full step class 2 in mixed dentition on those patients of class 3, you know?
Yes.
For having a liability policy that we are going to have a scenario that we look for at the end of the phase 1. No?
Okay. Then what I personally do when I use them in the primary dentition is I will put a Nance holding arch.
Very interesting.
And hold the molars in superclass 1 position, and then wait for all of the primary teeth to come in and establish an occlusion when the premolars come in.
Correct.
And that seems to work very well. I've probably done maybe 3 or 4 now class 3 motions, and I'm anxious to see how they establish themselves as far as retention is concerned.
Yeah, I don't do that. It's very interesting and it's a very good option, but I don't do this. One second. Excuse me. Yeah, I don't do this, but it's an approach that is very interesting. I'm a simplifier. Once we accomplish the class 1 occlusal platform or overcorrected class 1, we leave it. And we leave it alone, because then probably we will need the second stage of treatment, and then will be the moment in which that we are going to have. But placing an ANS also is a very interesting one. Yeah.
Do you have any other innovative appliances being worked on currently?
Yes. Now here we have in Arizona in our HSO symposium that we are holding here in Scottsdale those days, we have pre-presented, and just unveiled. How do you call it? Just revealed which will be the next generation of brackets. We have a new bracket, a beautiful self-ligating bracket that is aesthetic, that is the Carriere SLX 3D clear bracket. This is an amazing bracket. Has been very difficult to arrive to this design, but now we have created a bracket with a fantastic rotational control. The sliding door will cover the full body of the bracket, so the rotational control will be completely amazing and is a piece of art that has been done by our engineers in Henry-Schein.
Did you say it was clear?
Yeah, it's a ceramic bracket. Yeah, correct.
Ceramic bracket that's self-ligating.
Yeah, but high end.
High end. I'm anxious to see what that looks like. That's wonderful. How about in the world of appliances such as the distalizer? Are you working on anything different than that?
Well, we have a big family of motion appliances or distalizers, as you say. We have the traditional one that is a metal one. Then we have the colors, which is very fancy set of colors. Patients that want to have color motions or color distalizers, they place them and they use them beautifully and they look amazing because we have purple, blue, green, gold, etc. And then we have the beautiful clear motion, which is completely crystal clear, clean, ultra minimalist, and so chic, no? So elegant for those patients that are looking for Invisaligns or for aligners or for an aesthetic approach. No?
I think it's very interesting that you use your motion appliances even when you already have a Class 1 case.
Yeah, correct.
Can you explain that? And you also use the Motion 3 when you have lower anterior crowding. Can you explain the reason why?
Imagine that you have a lower crowding in the lower arch, and you have a Class 1 scenario. What we prefer to do? We prefer to place the Class 3 motion appliance, open slim spaces in between the lower incisors. Then we can do a clean reduction of those collision points if we want to do a certain stripping in between the incisors without removing necessary material from the teeth, because we are dealing with a little bit of spaces. And then the alignment of the lower arch is beautiful, easy, super quick and simple, and everything settles again into Class 1, again, after this alignment. So it's a matter of simplifying in a very easy way, generating slim spaces in between the lower incisors and generating the scenario for perfection of correction of this.
But you're using it you're using the distalizer as, I keep saying the distalizer, the Motion 2 appliance for Class 1s as well.
Sometimes if we are having crowding in the upper teeth and we don't want to procline the upper incisors by leveling with the brackets, what we do is we place the Class 2 motion appliance and we look for what we call a Super Class 1. Super Class 1 means Class 1 matching occlusion of the posterior segments, in which we are going to rotate beautifully the molars around the palatal root to the distal and generate an intimate intercuspidation of the premolars and canines together with the lower arch. Sometimes cases that it looks like that they are in Class 1, if we really look them from the side, they are a little bit in Class 2. And the reason of that is because the molars are medially rotated. And these molars medially rotated are pushing forward the premolars and canines, disoccluding them into a little bit of Class 2, but apparently looks that is a Class 1. So what we are going to do is to invite to those molars to rotate to the distal, and suddenly everything, premolars and canines, will settle in a perfect Class 1. And slim spaces will appear in between the upper incisors, that then, while leveling them, we are not going to procline, and we are going to establish a beautiful finishing with a very short period of time.
Very, very interesting. Luis, you have opened up my mind to new thoughts and new ways of using the motion appliance, and I know you're very busy there in Scottsdale, so I want to thank you so much for being on Orthodontic Smiles. I look forward to seeing you again in person and enjoying your lectures and the new things that you have in store for those of us that do orthodontics. So thank you so much for being with us.
Thank you to you, Ed. It has been a true pleasure. I was looking forward to having one meeting with you and meeting you personally. So thank you very much for taking your time and for this beautiful interview.
I hope you look forward to hearing yourself on Orthodontic Smiles.
Thank you. Congratulations for this project.
This is your host, Dr. Ed Gonzalez. I want to thank you for listening to Orthodontic Smiles today. If you enjoyed our broadcast, please click the subscribe button. We'll be in touch with you in the future about our further broadcasts. Thanks for listening.